very good afternoon, everyone. We at the Muscular Department of Sri Kashibai Navle College of Physiotherapy are extremely glad to be here presenting before you a webinar which is very it is a very known topic to all of us, that is International Classification of Functioning, Disability and Health, which is commonly known as ICF. Okay, so we apply it during our day-to-day lives, but there are still many things that remain unclear to us. So for this today, to guide us, we have Dr. Apurv Shimpi sir, who has specialized in community and sports physiotherapy and holds a PhD degree under MUHS. He also has a fellowship in orthopedics and sports physiotherapy, USA, and is a certified ICF facilitator from the Dutch WHO FIC Center, Netherlands. Sir is currently the principal and professor at the Shimpi College of Physiotherapy and also is the chairperson of IAP Research Committee for the West Zone. Sir has more than 25 publications with more than 110 citations in the peer-reviewed index journals to his credits, including the Shimpi Prone SIJ joint test. Sir is also the winner of the Innovative Award from the Nehru Science Center and a two-time winner of the IAP Research Conference paper presentation. He has been privileged to represent India and present his two research papers on ICF at the 4th International Symposium on ICF Education Kuwait, sponsored by the Ministry of Health Kuwait. So, sir, I welcome you. Over to you.
Well, thank you so much, ma'am, for the kind introduction. I hope you can hear me well.
Sir, I cannot hear you.
Okay, am I audible right now?
Yes, sir.
Okay, thank you so much. We'll just begin with the topic. Just give me a minute. I hope our participants are able to see the screen.
Yes, sir.
Okay. Well, thank you. Okay. So, first and foremost, thank you to the organizing team and the muscular department of Kashibai Navle College of Physiotherapy for inviting me for this very important topic on understanding the basics of International Classification of Functioning, Disability and Health as applied to the clinical practice. Now, we have the ICF domain in our syllabus. It is something that we all need to talk about on a regular basis. Okay, but as an undergrad, even as a postgrad, sometimes even as a faculty, there are a lot of confusions that all of us have as to how exactly we should be talking on ICF, what we should talk on ICF. Do we need to talk about the codes? And that's the biggest phobia everybody has every time. And what do I really do? How do I use this in my clinical domain? So we are going to try to solve a few of the queries that everybody has. In case you are not able to hear me, please interrupt me and let me know. If you have any queries or questions, we can hold it to the end of the talk and then we can discuss on them. Okay. Now, the ICF, that is the International Classification of Functioning, Disability and Health, is proposed by the World Health Organization Family of International Classifications, also called as the FIC. Now, we all are very well versed with ICF, but for your kind understanding, there is something called as the ICD, that is International Classification of Diseases, which is used widely more than now 50-60 years. This is in use. Rather, right now, the latest is ICD 11th version. ICD is what actually diagnoses the problem. So most of the times in clinical scenario, when we start talking on diagnosis, okay, it's ICD who talks of diagnosis, not ICF. ICF purely talks of functioning. And recently, this is almost since the past 1 or 2 years, WHO has also introduced something called as ICHI, International Classification of Health Interventions. ICD looks at disease and diagnosis. ICF looks at functioning, disability, and health. ICHI is what talks about the interventions, treatment domains. This includes medical treatment domain, physiotherapy treatment domain, on a lot of components. And I have been privileged and lucky to to have worked on ICHI along with WHO FIC Italy Center. So this actually gives a good perspective to a lot of us to understand what the concepts all are about. So let's talk of the talk for today, that is International Classification of Functioning, Disability and Health. Now, when we talk of the International Classification of Functioning, Disability and Health, this is not something which was not known. Like rather, this was a concept which was introduced quite some time back. There was a person called as Nagy who introduced the concept of ICF. He speculated that the traditional evaluation system that we are using, if we all remember the name, age, address, occupation, present history, past history, family history, socioeconomic history, observation, palpation, examination, on all these domains, the evaluation was devoid of each other. They are not understanding. For example, finally, I would like to know if the patient has a swelling, or if the person has a bad posture, or if he has a deformity, or is there any no loss of functioning. So that was more important. And what was observed that with the traditional model, it was difficult to evaluate. And that is why the concept of ICIDH was proposed. That is the International Classification of Impairment, Disability and Handicap. This, rather than talking only on the disease and diagnosis, started talking on the disability of the patient and also on the handicap, that is his problem in participation in the society. But again, the terms disability and handicap especially were not very appealing. Many people, especially persons with disabilities, started feeling you know, down that they are being labeled as handicap. And so the domain of ICIDH2 was introduced, where instead of using the word disability, we started using the word activity limitations, and handicap, the word was replaced by participation restriction. Okay, so again, please understand, ICF does not talk of diseases and diagnosis. ICF talks on functioning, and more important is activities and participation, which is a direct representation of functioning. But again, in ICIDH, the components of were a lot of negativities, rather inabilities of the patient were seen rather than the abilities. And hence, the domain of ICF was introduced, where rather than activity limitations and participation restrictions, emphasis was laid more on functioning. That is what the patient can do rather than what the patient can't do. Okay, but nevertheless, somehow when we look at ICF till date, we are generally looking at more of his impairments and disabilities for us to diagnose, for us to plan the treatment intervention and so on. So as I just said, it is a common international framework talking on a global domain, and it is a multi-purpose classification system with a lot of different sectoral aspects. See, I understand, as I said earlier, ICF is purely a classification system. What we are doing in our clinical practice, most of us as undergrad students or even as postgrad students, is something different. But if you look if you look at ICF by itself, it is purely a classification system. It just looks at different domains of what the problems of the patient are. So ICF helps us to describe the change in body function and structure. It also helps us understand what a person with a health condition can do in a standard environment, that is where they are usually performing, and in their usual environment, that is where they actually live, their home environment. ICF is named as it is stressing more on health and functioning rather than only disability. Now, why this is so? See, if you look at the diagnosis, for example, I have a patient with low back pain, or I have a patient with ONEs, I have a patient with stroke. The diagnosis cannot predict what is the length of service that the patient needs, how, if they are hospitalized, what are the components related to hospitalization. It it does not talk about a lot of domains of the patient. Okay, so it is very important that the patient, it is very important that the patient is looked at from his abilities to do something rather than looking at from the diagnosis perspective. And all of you will agree rather that till now we all are trained to look at the diagnosis. We still talk in terms of it. I am presenting that TKR case, I'm presenting that stroke case. Okay, let's understand. TKR is not a case. TKR is a health intervention. So do not go on that domains. And second, do not diagnose a patient because you cannot talk about level of care and activities or outcomes depending on diagnosis. Again, the disease or disorder is not an accurate predictor of the disability benefits. What the patient should be given, what chances, what help, what scope, what social factors the patient should be given. Okay, so all understanding these domains are very important from all of us. Again, now many of the, like for example, all of you must be aware of the RCI norms for disability evaluation, which does talk about what are the levels of impairment, what are the problems with the patient. Amputation के लिए अलग है, movement, mobility, strength, A plus B 90 divided by we are used to having a specific formula. But all of that again emphasis a lot on the structural domains, whereas the functioning of a patient, that is the activity and participation, is a true level of the individual's functioning. And that is the reason why understanding activity and participation is more important rather than structure and function. But again, in our routine clinical practice, we are taught to talk more on function, range, pain, mobility, posture, and other aspects. So
दारा आप लोग को भी देखने को मिलता।
मेरे माइक का कुछ प्रॉब्लम है, आई डोंट नो इफ इट्स
just give me one sec, please.
बात
Okay, sorry for the disturbance. Thank you. Okay, again, when we are talking from the component of ICF, reduction in incidence and severity of a disease in a population can be brought about by enhancing the functional capacity. I'll give a very simple example. You have a patient who is a case of stroke and it has been 3 months since he has got the episode of stroke. Now, what is more important is what can you do in terms of his structure function or in terms of his contextual factors, that is his environmental factors, to make him functionally independent. What is more important is his functional independence. It does not matter कि उसका tone कितना है, how much is his mobility. Yeah, now we will go into a controversy. Why is he saying that? See, I agree to the fact that it is important for us to get the mobility, the range, the tone normalization and everything. But really what matters is whether my patient can do what he's supposed to do in the given circumstances or scenario. If I can favor the environment to make him more functionally independent, well, let me do so. If I can make his structure or function better to facilitate his functional independence, let me do so. So ultimately, from a physiotherapist point of view, what is more important is the functioning. वो क्या कर सकता है? Can he do or he cannot do? And what can I do as a therapist to take care of these domains? Okay, but traditionally we generally talk in terms of, we give a lot of importance to the structure and functional impairments with a very poor or minimal involvement of the environment, which actually has a very important role. Okay, I'll just give a small example for all of you to understand. Let's say I have two patients with me. Both are 25-year-old males. Both have spinal cord injury at L3 level. Okay, 25-year-old male, spinal cord injury at L3, complete transaction. Same clinical picture. One of the patient stays in a rural setup in Pune. The second patient stays in a penthouse in Manhattan, New York. Just this domain, just this environmental variability itself can talk, because he's staying in a developed country, he may have access to resources, economic domains, caregivers, caretakers, norms and policies. This itself can make that person staying in the penthouse in US make him more functionally independent as against the patient who has the same clinical features. but staying in a rural setup. Okay, so just the level of impairment, just the diagnosis, the level cannot determine what the person can do or can't do. And that's the reason why knowing the environmental domain is very, very important. Okay, so there are a lot of other applications. Now, this is some theoretical domain. I'm not going to go into the details, but ICF can tell us at the individual level also the level of functioning of the patient, what treatment or interventions can help him, which we are going to talk of goal setting also with this. What are the outcomes? What should I use to evaluate? ICF is a good it can be used as an outcome measure, but ICF does propose that you can use other outcome measures also. For example, you can use a FIM, functional independence measure, in addition to an ICF to talk of the level of impairment. That's okay. So you can use other clinical interventions also along with this. It is a common communication between physicians, nurses, physiotherapists, and other healthcare workers. So it's not like sirf physio is going to talk on ICF. No, it's a language for everybody. And it can help the person understand their level of functioning because they decide what they can do in their given environment. We don't determine, okay, your range is full, your strength is good, you should be able to do this. No, they decide within their given domains, can they do it or can they not do it? That's why their environment is more different, more important rather than our OPD setup, our standard environment. What is more important is their real life environment. And then there are utilizations at educational level, planning and development, quality improvisation, because you can get a good documentation. We have to be more accountable when we exactly show what we are doing to the patient. So a better healthcare delivery and a good quality is what ICF proposes. And again, social level, giving disability benefits, improving function at social level, all these factors ICF can propose. ICF can also talk about issues of a person at their different levels and how they can be made social. So how can we make the social and better environment to be accessible to persons? So it just does not talk about treating the person. It also talks about what are the accessibility needs and challenges that needs to be overcome. For example, all of you know Pune mein right now we have the metro coming up very nicely. Before the metro, all of you must be aware, we have those BRT buses, the ones who have the door on the right side, in the center of the road, there are the platforms. So why the BRT system was introduced? Why the metro system is introducing is not just for better connectivity for all of us. It is a better connectivity for all, including persons with disabilities. You must be aware that these BRT buses and metros are very, very wheelchair friendly. A person on a wheelchair can also directly access or go through various levels. So this is what a sign of progress is all about. Now, coming to the main topic. So finally, once we are aware more or less about why ICF, how it would be used, let us talk about what is there in ICF. ICF consists of two components. One is the functioning and disability, okay, which talks about two components. Functioning means what the patient can do, disability, what the patient can't do. Okay, so both are important. In functioning and disability, we talk of body functions and body structures, and we also talk of activities and participation. We'll go through all of this individually. What we tend to ignore most of the times is the part 2, which is equally important, having almost 50% weightage, is the contextual factors, namely the environmental factors and personal factors. Now, what are the challenges and personal factors? We'll talk about that later. And why environmental factors should be looked at and how it should be looked at, that also we'll talk of. All these domains, body function, structure, activity, participation, environment, personal, they all have a positive aspect and a negative aspect. Positive talking of what is good about these systems. Negative talks about what is not good or what needs to be worked on. Okay, so these are the basic unit of classification. Now ICF looks at two different domains, or rather it's a conjoined framework. If you look at the diagram on the screen, ICF has, we generally have something called as the health condition. This is the disease or diagnosis that all of us are aware about. Okay, the diagnosis. This diagnosis is important. Ideally, it is better if you have a diagnosis of a condition for helping you to go ahead with the ICF. But suppose you do not have it, it doesn't matter, because ultimately we are looking at what is the level of functioning of an individual. And the cases, the examples that I have given later, which we'll be discussing, are generally based on what if we do not have a proper diagnosis of the patient. Now we have something that we just saw: body functions and structures, activity, participation, and environmental and personal factors. Now all of this are interlinked with each other. They all are dependent on each other. So let's look at what is a body function and impairment in body functions. Body functions are physiological functions of the body system, okay, and they include psychological functions, whereas impairments are problems in the body functions which is looked at like as a significant deviation or a loss. Now if we talk in terms of body function, there are numerous body functions. If you open ICF, it has all these components actually documented down. You may have mental function, sensory function, voice, cardiovascular, hematological, respiratory, genitourinary, and so on and so forth. Function is denoted by a small b. Okay, don't ignore what has been written up. It's not a capital B, it's a small b. Now if you go into all these domains, there are a lot of functions. Now there's a time to slightly get confused, but it's okay. Don't get confused by the lot of things that you're seeing on the screen. It is generally how the things are denoted in ICF. As I said, you have a code system, for example, B1 mental function, B2 sensory, B7 neuromuscular and movement related. And then there are certain further chapters, components or so. We'll talk of this later. So for example, if we look at B710, it might be related to mobility. 710 1, 2, 3 might be mobility of upper limb, lower limb, trunk, lower, and so on and so forth. So there are a lot of components that are there. And the way we have our grading of MMT, okay, we have simple grading of problems. That is, how much are these functions impaired? So 0 means there is no impairment. 1 is mild impairment, around 25%. 2 is moderate impairment, around 50%. 3, severe impairment, more than 50% to around 75%. Rather, to be more specific, 50% to 90%, 95%. And 4 is complete impairment, like more than 95%. Okay, so this is the essential classification. So if, let's say, a person has problem of mobility of a joint, so if I write B710.3, I would like to say that he has a severe impairment that is more than 50% with that particular component. Then there is generally a question mark. What is this 8 and 9? Why do we really need to write it? Okay, sometimes you may not be having the complete information. So if you have insufficient information, like you don't know, for example, what side is involved or how much is the level of involvement or so. So you can't write 1, 2, 3, 4 because you don't know how much is the problem. In that moment, you can write 8. Okay. If, for example, it is not related to that particular individual, then it goes as 9. So as I was explaining about the qualifiers, they are as good as the grading systems. So 0, 1, 2, 3, 4. Okay. And why 8 and 9? Why not 5 and 6? Okay, simple. It should not cause confusion. Galti say if I forget that, okay, the grades were only till 4 and somehow I'll end up giving 5. So there should be no confusion. That's why there's clearly a demarcation on 8 and 9. The next was impairments of body structure. Now, body structure are anatomical parts of the body such as organs, limbs, or components. It includes brain, liver, lung, kidney, everything. And impairments are problem in structure as a significant deviation or loss. So when we are talking of body structure, you can have a lot of domains again over here: structure of the nervous system, eye, ear, voice, digestive system related to movement, skin, a lot of things. Oh, we jumped. No, yeah. And as with the body function, there are a lot of domains. The same components of coding are applicable to structure. Structure is denoted by small s. Body function was by a small b. Structure is with s. And here also you have first level, second level qualifiers and so on. So you have the S110, or you have like S710 for head and neck. Shoulder, you have S720 and so forth. Same as function, we have a first level qualifier for structure also with 0, 1, 2, 3, 4, 8 and 9. What is different in this is in structure, we have a second level of qualifier also. That is 0 to 9. Now here, as in the first qualifier, if you look at first qualifier, they are an incremental order. Okay, it's an ordinal type of data. 0, 1 is more than 0, 2 is more, 3 is more, 4 is more. So it's an incremental order. Whereas second qualifier is not of any increment, it's a nominal data. The 1, 2, 3, 4 are pure numbers. They do not have any meanings. They are not in incremental or decremental order. Okay, so it's just to denote if there is a total absence or a partial absence, or there is an additional part, or there is a swelling or anything. For example, 7 qualitative change in structure including fluid, that can be applicable for the lungs if there is a hydrothorax or so, and it can be even for the knee if there is a effusion also. That is the second level qualifier. Now next comes the more important part on activity and participation. Now maybe I find it more important because I am a community physiotherapist. But why it is more important, as I said earlier, is because it denotes functioning of the patient. My ultimate measure of a person's ability to do something is based on what is their activity and participation. Okay, and that's why it is an important measure. Activity is execution of a task or an action. What we do every day: eating, bathing, drinking, combing, toileting, whatsoever. And participation is involvement in life situation. Going to the college, going for play, going to a discotheque, going to school, going out with relatives, can be multiple examples. Activity limitations are difficulties an individual may have, or difficulties that an individual may experience in executing an activity. Participation restrictions are problems that an individual may have in getting involved in life situations. Now, activity and participation are a single unit. Okay, generally we all are used to having activities different and participation different. Yes, it's not wrong because they are two different domains, but in ICF they are under a single heading, which is represented by small d. Okay, it's represented by small d, but ICF also gives you the permission or the consent. If you want to describe only activities, you may use a small a, and if you are describing only participation, you may use a small p. Okay, but in totality together they are represented as a small d. Activity and participation can have a lot of the domains like learning and applying knowledge, general tasks, communication, self-care, major life areas, mobility, domestic life, and so on and so forth. This is by far the most biggest domain. So if you look at the list of activity and participation, okay, there can be numerous things. Maybe for those of you who are looking at this on their cell phones, you might find reading this a bit small or so, but it's okay. You can always refer to the ICF checklist. All these details you'll find over there. Okay. So learning, general tasks, communication, mobility, self-care. Again, what mobility? D4, 6, 5. Using, for example, for our patients, moving around using equipments. So patient have mobility, but by using an assistive device. That's okay. So that is, again, there's a code in all those aspects. Then participation in terms of domestic life, interpersonal relationship, major life areas, social and civic life, a lot of other domains for this. Now, activity and participation has something called as a performance qualifier and a capacity qualifier. Now, again, this is somewhere where the confusion starts. This is also called as a domain. You can call it as a qualifier or you can call it as a domain if you don't want to go into confusion. Performance qualifier indicates the extent of participation restriction by describing the person's actual performance of a task or action in his or her current environment. Simply put, performance is what they can do right now. Okay, so current environment brings in a lot of domains. It can be understood as involvement in life situations, the lived experience, okay, a lot of components or domains. So easily put in, performance qualifier describes your individual's ability to do that task in the current environment. Okay, अभी के phase में आप क्या कर रहे हो? Whereas capacity domain indicates the extent of activity or participation executed or that is the ability to execute. आप कितना कर सकते हो? Simply put in, performance is what you can do. Capacity is to what level you can do. आप कितने level तक कितना जा. So capacity can somewhere give you the ability, the goal to where you can actually take an individual. Capacity qualifier focuses on limitations that are inherent or intrinsic feature of a person. This limitation should be direct manifestation of the health state without assistance. Means बिना कुछ assistive device के, without any support, finally कहाँ तक आप उसको लेके जा सकते हो. So capacity qualifier describes an individual's ability to execute a task or an act. It's your ability. It's not your level. आप भी कर रहे हो वो नहीं है. कितने level तक कहाँ तक लेके जा सकते हैं आप उसको. Example of the same domain, I have a patient with spinal cord injury at L3. Okay. And currently the patient is ambulating with the help of a wheelchair. Now, should I give him an orthosis, maybe an HKFO or any other thing or a corset or a brace so that he can be made to stand or with a walker? ये मुझे define करने के लिए, ये समझने के लिए I need to understand his problem, level of impairment, and what is the level of trainability. See, no point, for example, if in spite of doing everything, you are not in a position to make him walk on an assisted device or so, then why unnecessarily ask him to spend that money? We have to think from the socioeconomic domain also of the patient. We can't just experiment. And for that reason, you need to understand their level, their problems, and to what level are they trainable. Okay. So I'm not going to the more details of performance and capacity. Simply put in, performance is what you are doing. Capacity is to what level you can do something in an ideal environment. So when you are, for example, talking of performance and capacity qualifiers, let's say I have mobility D4. Okay. Now, when I'm going to mobility at D4, performance might be currently, he might be 3. That is, his limitation is more than 50%. But I can train him. I can make him give some assisted device, do something or the other, and get him till at least 1. So my performance is 3, capacity is 1. Capacity is not what I am seeing in him right now. Capacity generally denotes my goal of treatment. मैं कहाँ तक वो patient के? Why not 0? Maybe I know, looking at the problem, looking at the pathology, looking at the structural domains, कि शायद getting him to a not impairment or 0 means no impairment. Getting him to that level might not be possible. See, that's what we can define. We are professionals, we are therapists. Our clinical knowledge and experience teaches us a lot of things. So that is what we can actually write in these domains. Apart from this, if you don't understand, forget it, ignore. Okay, don't get confused. If you are not able to, when you try over a period of time, you will be able to remember this more better. And next, we talk of the important domain which we tend to ignore. The contextual factor में the environmental factor. Environmental factors make up the physical, social, and attitudinal environment in which the person lives and conducts their life. Unlike in the structure and function where we had only no impairment, then mild, moderate, severe, or complete, that is 1, 2, 3, 4. environment mein you have facilitators and barriers. You have things that have problems. You have things that can help the patient. There must be something which are both. Okay, just understand. For example, let's say you have a patient who is a spastic diplegic and he has a mother who is taking care of him. It's a facilitator, but the mother is taking so much care taking so much of care of the child that she is not allowing him to naturally grow. When he gets some challenges, some difficulties, he will take. She is taking care of a lot of things. She is giving him water to drink. She is feeding him. She is taking care of his toilet, bathroom, everything. The child is not getting a scope to develop. So that time it might be a barrier also. So rarely you might have something. I'll give you another example. Let's say the patient is on medications. कौन सा medication? Let's say some anti-Parkinsonism drug. The medicine is giving him the betterment of mobility, movement or so. But let's say the medicine is also impeding his general level of functioning, maybe his state of arousal or consciousness, causing him, giving him more sleep or so. So that same can be a barrier. So you have to weigh which is more important. Okay. But more or less in your clinical practice, you will get things which are either a facilitator or a barrier. Itna khichdi nahi milega. This was some extreme example that I was giving you. If you have a facilitator, they are given as 0, +1, +2, +3, +4. Barriers 0, 1, 2, 3, 4. Again, remember ICF, positive outlook, no negative, no minus. Environmental factors looks at a lot of things. It is denoted by small e, and it looks at products and technology, natural environment, support system, relationship, attitudes and all. For us in our routine case presentation, where does environmental factors go? Patient has an Indian toilet, end of story. Patient is motivated, end of story. Why? I mean, there are so many domains which actually look up to the environmental factor. Why only look at something very non-specific? So what is environmental factor? You can have products and technology for personal consumption, design and construction, architectural factors. Jaisa abhi I was giving example of metro and BRT system, natural and human-made changes, that is climate, light, sound, support and relationship, caregivers, family caregivers or paid caregivers. Okay, support people in position or authority, somebody to guide him, personal care providers like professional healthcare professionals like us. Having a physiotherapist to give you a treatment is a very important thing. It is E355 +4 because we are very good and we are the best healthcare givers. Okay, we are part of a team. Let me be clear on that. Attitudes. How are we looking at people with disability? Are we looking at them with discrimination? Are we actually saying that, okay, he should not be included in the routine domains or so? So attitudes of individuals, societies, healthcare providers, everybody, including us. Service systems and policies, transportation, housing, communications, legal systems, social securities. Okay, now many of these are there in India. ISF ऐसा नहीं है कि ये हमारे country में नहीं है. Most of these are there and they are very nicely provided. Just that you need to know to what level, or suppose they are not there, then are they causing any barriers to the healthcare of the patient? And last domain of the contextual factors is the personal facilitator. Now, like all the other domains, personal facilitators does not have a personal factor, sorry, does not have a facilitator or a barrier or a positive or a negative, because no, per se, there are so many domains. For example, you have age, you have gender, lifestyle, habits, background, educational level, sexual orientation, race, ethnicity. These are very different to be categorized. Usme bhi there are some factors like age and gender which are not even modifiable, although they are considered, but they are not modifiable. So there's no point in even considering them. You can't say XYZ age is a facilitator or a barrier, or a gender is a facilitator or a barrier. Okay, you might have somebody who is having a job or who is educated but not getting a job. So sometimes personal factors do not make up to a lot of things. So it is very difficult to categorize. So please do not go into categorization of personal factors. It's not possible in ICF. So this is finally an overview. You have functioning and disability, and you have contextual factors. You have components like domain, construct, positive and negative aspects. Usme you have functional body function structures, activity participation, environment and personal, and so on and so forth. You maybe you would like to have a screenshot of this, or this is available even on the ICF site. It's not like something very impossible to get. So why use the ICF? Okay, understand that ICF gives you a better patient experience. You are not limited to only diagnosing of a problem. That's what the physicians do. They diagnose a problem. You are limited to looking at a patient holistically. You are actually involved in looking at his activities, what he is doing, whether that can be used in his day-to-day care, what are the environmental domains, what are his problems. So it gives you a 360 view of your client. That's why it is a bio, psycho, socio, spiritual approach to patient. It looks as his health conditions and problems, his emotional domains, social factors, and even spiritual well-being, because that is something which is very important for most of our clients. It improves the health outcomes because you are getting an accountability. You are actually looking for why the particular problem is, how much is the level of involvement, and what is my goal to change. That is when you are accountable. It helps strengthening of the health systems because you are documenting a progress, you are documenting a process across a population. It helps in improving interprofessional education, collaboration, and practice because we all talk of the same things, whether you are in India, China, Russia, Brazil, wherever, we all talk of the same thing without getting confusion. And because of this, we are talking of a task sharing and a shifting rather than fighting over what is my right as a healthcare professional. We are distributing the load amongst all of us. So let's try and understand how do we finally go ahead with the system with a couple of examples. Okay, this is my case example 1. Okay, you can just read it for a minute.
Yes, sir. So a 55-year-old male is referred to you with complaints of breathlessness, dyspnea grade 3, cough and mucoid sputum since 2 years. He has been working as a construction site laborer and is a BD smoker since 27 years. His PFT shows a reduced FEV1 by FVC ratio with a poor reversibility to bronchodilators. He has 2 minor children and stays in a hut meant near the construction site. Write his functional diagnosis with clinical reasoning as per ICF.
Thank you so much, ma'am. So this is very common that we can get as a case. This is very common that we can have, as a example or so. Now, if you look at all these domains, they are giving you some subtle hints. For example, they are giving you hints about some problem in his functioning, some problem in his occupation, maybe some addictions, his investigations, because how you come to a clinical reasoning is based on some diagnosis and some challenges that he has to encounter. So if we go ahead, okay, again, this is very vaguely that I have tried to do to make you understand. 55-year-old male with breathlessness. Now this might be a COPD. I don't know. It's a possible diagnosis. We are not going through ICD. So I'm not diagnosing the patient in this. Structural impairment can be involvement of the bronchial tree and the alveoli. Okay. Now I have marked on this because if you see again, there are numerous codings. So there's S430, that is involvement of the structural involvement of the respiratory system. And then there are further 1 and 0. Now what this further 1 and 0 is, that we'll talk of later. But they are generally the codes for those particular domains. Then his functional impairments, He has cough with mucoid expectorations, which you might have found because of the history. The reasoning can be because of the pathology. What are the changes? You can document those. Then he has dyspnea grade 3. Why dyspnea grade 3? How much exactly is dyspnea grade 3 as per NYHA classification? What happens when somebody has grade 3 dyspnea? He also has bronchospasm. That is, how do we know he has bronchospasm? He has reduced FEV1 and FVC ratio, not reversible. Maybe sometimes you will get the MVV, which actually talks on small respiratory muscles involvement also. Activity participation, he has involvement in daily tasks, and he has difficulty in working as a construction site laborer. I might as well like to know what are the challenges, what are the demands of his job, why is it that he cannot be involved in this. Okay, so I have not written those clinical reasonings and the findings that we need to evaluate in the patient. In contextual factors, as I said, personal, no, addictions has no scope. We have tried to look into a lot, but there is no coding for, no system for identification of addictions. But yes, he has a poor socioeconomic condition and he has no permanent residence. Now here again, some of you may have this query, why I have written D and E, D and E both. Okay, D is activity and participation. Well, E is environment. So of course, he is environmentally also, he is not in a position to go for a permanent paid job, but he is not even has the, D870 is ability to maintain financial aspects. आपके पास पैसा है, लेकिन वो पैसे को properly manage करने को भी आपको आना चाहिए. That is your financial resourcing. Similar goes for housing. For example, E16515250 talks of having a house, provision for having a house. This is having a rented or a permanent housing, ability to go through that. So even if we are talking of contextual factors, there is always an interplay. There is always an exchange of concepts. And he has family. Now here, see, again, I have not written whether it's a facilitator or a barrier. I have written it on the second example. But just for us to understand that there are a lot of factors that we can actually talk about this. Okay, so next question. Should we have codes every time? Well, as I said, ICF is a classification system. So technically, you have to have the codes. But if you are not having the codes, it's still okay as long as you are understanding the problems. Okay, so ideally, yes, you need to have codes, but even if you do not remember, do not write, it's okay. Because generally then we'll get tensed ki, Arey, abhi kya karne ka? What do we do in our exams and everything? It's fine. Don't bother with that. So I was telling you what all these components are. So ICF, as I told you earlier, it has this functioning and disability and contextual two parts. These parts are divided into components like body function structure, activity participation, environmental and personal. Personal is not classified. These components are further divided into categories and chapters. Okay, so ये जो आपने देखा ना, S430. So S430 can be till my component, and maybe 4 was my structural component and 30 was my category. Okay, if you look at over here also, B1 single digit, triple digit, 4 digit, 5 digit. So every time you go to more and more levels, your digits go on increasing. And suppose you have reached to the fourth level, S76009. You have reached to this level, and whether you want to put it as a facilitator, you want to put it as a qualifier, then you might put S76009.1 or 0.2 or 0.3. अगर structural में second level पे जा रहे हो तो 31, 32, 35, 37. Okay. This is just for your understanding of how codes are used. If you start using it, this is especially for the PGs who are attending this. If you start using this, you'll understand. Okay, so try and open the checklist with you. Whenever you have certain conditions, whenever you are documenting certain findings and classifying the way we have did, try and categorize what these codes are. Now again, you will ask me कि ये कहाँ से करते बैठे, ये कौन से book से इतना ढूंढे. I will give you certain suggestions for this. So you have to wait to the end of my talk, where I am actually giving you certain good online websites which you can make this work very easy. Okay. So if you look at ICF, part functioning and contextual factors, so component level, body function, structure, activity, environment, personal. First level chapter में हमने example देखा B, S, D, E. Second level में suppose let's go for body function B2 sensory function and pain. 2 में 30 hearing function. 3 B230 में 0 sound detection. Patient has mild impairment B2300.1. Okay, this is how you land up writing the codes. And all over the world, B230.1 will mean the same. You can additionally give your notes. For example, you want to say left ear or right ear or whatever, or bilateral also, you can have additional notes. But by far, this is the system. So let's go for a second example.
Yes,
42-year-old.
A 42-year-old female came to you with right dominant shoulder pain since 1 week. Pain was insidious in onset with VAS of 7 on 10 on movement.
Okay. Presently, her shoulder ranges are limited to more than 50% and strength is 4 on MMT. She is diabetic with fasting BSL of more than 150. Teacher by profession and from an affluent family. Very cooperative and highly motivated towards her treatment. Write her functional diagnosis with clinical reasoning for the same. Now I have written over here, she is very cooperative and highly motivated also, because then we want to ask, where do we put it? We generally end up putting this in personal facilitators. But as I just told you, there is nothing like a personal facilitator. So, yeah. So health condition, 42-year-old female. Again, I'm not writing the diagnosis because possibly this might be a frozen shoulder. It has altogether a different code in ICD. Now structurally impaired. Now here I have tried to give you the qualifiers. S7208.27. S7208 is problem, structural issues or problems in the shoulder affecting the fascia or the ligaments. Point 2 was mild impairment, and 7 was also adding to some other aberrant dimensions or issues, including accumulation of fluid. So there was fibrous dysplasia, adhesions within the capsule. That's why I have written it as 7. So this is my code for this case, S7208.27. Okay, this is just for your understanding of the capsule in the shoulder with limitation of movements. That's with limitation. There was mild limitation. That's why I gave 2. That was less than 50%. Functional impairment. She has pain with VS 7 on 10. So 0.3 severe hai. And pain, especially to the shoulder joint, unilateral, only on one limb, is, that's why it is so and so. So B280 was my pain and unilateral limb and affecting the shoulder. इसलिए ये B28014 हो गया है. Then she has 50% limited range of motion. So उसके लिए ये code है. Loss of strength of grade 3 to 4, very minimal. So B730 was strength. Strength मतलब power. आप ICF में strength नहीं ढूंढ सकते, power categorization में है. 1 affecting only one muscle group and 0.1 is mild impairment. Now, she is very cooperative and motivated. This is a functional domain. B126 talks about the temperament of an individual. And B1301 is talking of the level of motivation. So they are functional domains rather than personal factors. For both, I have written 0.0 and 0.0. Now let me be very clear. Ideally in ICF, you will never write this as 0.0, 0.0 because 0.0 is no impairment. Here, in fact, we want to show she is very cooperative, highly motivated. But unlike contextual factors where you have facilitator and barrier, here you do not have any positive attribute. That's why I have just written 0.0, 0.0 means no impairment. Okay, but in real scenario, in your case, clinical scenario, this generally will not make sense. All I want you to understand is the ability, the temperament of the individual, cooperative, and the level of motivation or so can be written in function also, or rather is written in function. You do not have this classification in the structures. Activity and participation, involvement in daily task, जैसा पहले के example में भी देखा था, and difficulty in working as a teacher. So she has a paid job, full-time job. She has a job of good demand. That's why I have written this. Contextual factors, uncontrolled BSL. Uncontrolled BSL, भले मैंने contextual factor में डाला है, लेकिन uncontrolled BSL is basically diabetes, which is a health condition. It should go categorized. It should ideally be categorized in health condition. She has a stable job. So E330 हमने पहले भी देखा था, +3. So it is a good enough facilitator for her. And socioeconomic status and family support may be. Socioeconomic status may be ability to maintain finances, no issues, 0.0. She has a good socioeconomic status. So environmentally also, no issues, +3. Family support, immediate caretakers, very good support, +4. So this is basically how you document. This entire exercise is for you to actually understand how ICF has to be documented. Okay. Yeah. So somewhere like this, you will see, again, this is not related to the previous case. This is generally, you have something like a health condition, then you will have this body structure impairments, activities में भी आप abilities and limitations के 2 columns कर सकते हो. Participation में also you can have, then environmental, internal and external. So there are a lot of ways how you can go ahead with documenting ICF. Okay. Now the last part of the talk, till now we were looking at how we can use, or rather what is ICF and how we can use this information for documentation and categorization. Now we are just going to look at how we can use information provided to us by ICF for treatment setting of our patient. So one more case example, a 30-year-old postman who is from a village underwent a traumatic transtibial amputation on his right leg. Patient gives history of trauma to the right limb since 3 days and was operated 2 days ago. His range of motion for right knee is 20 to 90 degrees. Strength of extensors for right knee is 3, flexors 4. He has no other problems. He has to travel 25 kilometers daily for his job and stays on the ground floor in a pakka dwelling with toilet facility outside the house. Okay. So again, routine. अभी ये third BPTH some fourth BPTH में आ गए. So now we are not just told about functional diagnosis with clinical reasoning as per ICF, but we are also told planning a treatment goals for the same. Okay. So I am again now not characterizing the way we had done earlier, but let's go into the treatment aspects. Now, when we are doing goal setting for a patients, there are certain components that we can look. Always remember A, B, C, D, E. A is the actor, that is the patient, his needs, demands, and desires to fulfill a task or an activity. B is the behavior, that is need to perform or not to perform. C is the condition which is related to the task or activity. D is the demand of the task, that is the nature or duration of the activity, the demand. And E is the event time, that is the goal setting domain. So in this case, our patient wants to go back to his job as a postman, and he should be able to deliver the letters to all the houses by riding his cycle on the rough village roads in a period of 16 weeks or 4 months. This is how we can use. So जो हमने information categorize की है ICF से, जो हमने information break किया है, we are using this to formulate our treatment domains. Okay. So treatment, this is how you will apply this knowledge for clinical practice also. Now your treatment can be in two ways. Traditionally, we all are taught short-term goals and long-term goals. Fine, good. But what do you mean by term? Term is always time. So whenever you are setting short-term and long-term goal, always talk of how much is the duration of your short-term and how much is the duration of your long-term. Sometimes you can have multiple treatment objectives, which is again time-bound. Or rarely you might do something like a case study or a follow-up, okay, where you actually look into what was the finding, treat, again look at what was your findings, again treat, and so forth. Now this is generally what I'll end up not telling everybody, especially this is very, very useful for the 4th years. When we are giving a treatment aspect for a patient, always be specific to the dosages, be specific to what you're talking of. Because normally we'll end up giving very vague management to a patient. बहुत बार हम लोग बोलते हैं we can give IFT, we can give TENS, we can give IR. No, can give नहीं, what you should do and exactly how much you will do. So normally the treatment is divided as phase 1 or maximum protection phase, phase 2 moderate protection, phase 3 or minimum protection phase, and phase 4 or return to work. In this case, my short term or phase 1 maximum protection phase is 0 to 4 weeks. Here I'm talking of wound care, maybe by using infrared 15 minutes 2 times a day, 1 or 2 weeks, or cryotherapy if we are talking of pain and inflammation. For pain relief, his pain was 8 on 10. So my goal is at the end of 4 weeks, his pain should be 2 on 10. So remember ICF maybe we always have a, हमने sorry, सिर्फ performance और capacity में बोला था, लेकिन you always have a scope of telling where would you set your goals. So for pain management, I'll be using TENS, 150 Hertz, 4 electrodes, 2 over the sciatic nerve course, 2 over L4-S1 nerve roots on the right side, or you can use IFT now. Why TENS or why not IFT? You have to go through this. Ideally, there is something called as an evidence-based physiotherapy practice. This is altogether a different talk. Okay, I have this goal setting and ICF put on my blog, and even the evidence-based physiotherapy aspect, both of them are put on the blog. Anybody is interested can go through it. So you'll understand why I'm putting these values and how did I come to these aspects. Then strength or power. Strength training was grade 3 on MMT. So I want strength should be grade 4, for which I'm giving active exercises by calculating 1 RM or RP, whichever. Okay. You can go for closed chain strengthening for the normal side, upper limb closed chain strengthening. Okay, again, how much is the intensity? So look at the frequency, intensity, time and type. Because this is not the primary domain of ICF, that's why I'm going a bit fast with this. Range of motion, again his range was 15 to 65 degree. My goal is I should have 0 to 19 4 weeks. So I'm going for active range exercises for mobilization and whatever glide, whichever manual therapy concept you are comfortable with. Gait training right now is in non-weight bearing, so I'm choosing a 3-point non-weight bearing gait. Standing, swing to, progress to, swing through. So the basic logic is whatever information you have collected from ICF is being used for goal setting in a proper documentation. Moderate protection phase, again steps, stump shaping and conditioning, how you will go ahead with this, strengthening. So now what we are doing is gradually progressing. So we are reaching to our goal as we have planned. Range of motion, how we are going to go from the mobilization to active ROM, pre-prosthetic training, using a, I have to go for patellar tendon bearing prosthesis. So how I'm going to use that, and partial prosthesis or temporary prosthesis using pylon or walker. Minimum protection phase, again prosthetic training, how we'll go ahead with it, how strengthening will be given further with closed kinematic chain, proprioceptive training because he has undergone a loss of his limb, so this is also important for him. Gait training, again now in a controlled environment. So the entire domain of his gait training was determined by one, his performance, what he was able to do now, and his capacity, how much I can train him. So depending on performance and capacity, I am determining the entire domain of his gait training. Begin ambulation as per patient need, that is, let's say 10 meters, progression to 100 meters in 12 weeks. And last is return to work, because I know he has to ride a cycle on rough roads. So one, gait training on uneven surfaces in real environment, maybe preferably in patient's own environment. Training for cycling on a static cycle, half an hour, 4 times a day, 5 days a week. And a moving cycle in a controlled surface, that is normal cycle on a proper surface. So the treatment goal of being able to ride the cycle on rough village roads for 8 hours to deliver the raters should be achieved by the end of 16 weeks. Okay, this is a outline, because see, there might be issues, there might be infection, fever, any other challenges that we might encounter, but if you don't have a goal, you can't treat a patient. Okay, so planning and intervention is equally important. So depending on whatever, so I have a health condition. Based on the health condition, I am defining whether I want to go for medical treatment or care, or I have to go for prevention of a problem. So ICF, the health condition impairment activity and participation, also helps you determine what sort of active medical intervention is necessary or what preventive strategies are to be used. Okay, so both ways, this is very, very important. Excuse me. Okay, I hope this is being accepted and understood well. So this is how ICF can be used in goal setting also. Just want to take 2 minutes in sharing my experiences. This was at the International Symposium of ICF in Kuwait. So this was a WHO event, a WHO FIC event, where a lot of presenters across the globe, rather there was one member from each country, who actually talk of ICF and the expectations. The thing what I would like to talk about is universally, rather globally, physiotherapists are very active in using ICF in disability evaluation, categorization of problems, and treatment domains. Somewhere, we from developing countries are not taking this initiative very seriously, because unfortunately, most of the people who are doing this work very nicely are from the developed country. And the need to do this is in the developing country. So this is an appeal that I would like to make from this platform to all the participants who are listening, is be active in ICF intervention. Try and do ICF related studies for us to actually come on a global platform. There were 3 papers that we had presented. Factors contributing functional independence in children with CP in a developing nation using the ICF core set. Then we had used the ICF core set for global quantification of functioning. So the constructs and the chapters were all rounded up to get the scores of the summative scores. And one was factors contributing functional independence in patients with paraplegia. So these were the presentations that were used. And we also had an ICF facilitators course in India, which was collaborated with the WHO FIC Center from Netherlands. So there was a wide variety of participants from all over Maharashtra and India rather, who actually attended this session. And our facilitator is Dr. Catherine Sykes, who is a very, very active member of WHO FIC, who is very pro global education on ICF. Okay, so here are some important websites. You may like to note it down or take a screenshot of this or whatsoever. This is an ICF browser for this is on WHO site for which helps you for categorization. You have an ICF e-learning tool. This is icfeducation.org. You have to be a member of that to get access to this, but this has lot of articles and topics on ICF. There's something called as ICF illustration also. I have generally, what I have used is ICF browser. Very easy to use, very compatible, which actually can help you get the scores or the codings in a very easy manner. So again, especially the PGs, try to use this. And if you don't want to go through all the domains and understand, you have something called as ICF core sets. There are ready-made sets which are there for your clients. Again, they are generally validated in developed countries. You need to be careful when you are using them for our population, but they can be used. You have them for multiple musculoskeletal, neurological, cardiorespiratory, community domains. Okay. So that is all about ICF. I once again thank the organizers for inviting me, and my apologies for extending the time for the talk. I was given 1 minute, 1 hour, sorry. And I hope all of you are active in getting involved with the ICF education. Thank you once again. Over to you, ma'am.
Thank you so much, sir. So we'll have a question. So the question says, can ICF be used for acute conditions where patients are hospitalized and activities are limited, mainly due to operative needs or requirements? Example, lower limb fractured patients not allowed to walk. So how to put up the impairment and also environmental and contextual factors?
Okay, thank you for the question, ma'am. See, ICF can be used at any stage, but in the acute scenario, you would like to have more of the ICD rather than ICF because you would like to have more of the diagnosis of the problem. Because the patient is hospitalized and the patient is not in the true working environment or true living environment, understanding his activities and participation may not be possible, but determining his capacity is possible. He is in a plaster cast, so you don't even know to what level. And second thing is, it's not a true environment. For example, he does not have to go to the bath. He may be given a sponging. He need not go to the toilet. He may be using a bedpan. So even identifying current environment is a challenge. Okay. So for so acute scenario, using ICF may not make a very good sense. Rather, it's not contraindicated. But it does not make sense, at least till the time the patient starts doing some component in his environment. Okay. We have one more question. It's important for us to look at the functional independence. If a patient with stroke is able to ambulate with hemiplegic gait and has a facilitatory environment, should we break the synergy or let it be? Okay, very nice question. Thank you. And people are going to beat me in for this. I would say let it be, as long as you are achieving whatever you want to achieve. But then none of us will accept it. हम लोग सब लोग यही बोलेंगे ऐसा क्या बोल रहा है, because we all have been trained and told कि we have to break the synergy, we have to take care of the tightness, we have to give him the strength, irrespective of whether or not it is getting a benefit to the patient. The two papers that I presented, जो एक बीच का छोड़ा था, एक one left and right का, one was in spastic diplegic and one was in paraplegics. Both are results, both are researches actually show that environmental factors are more important to determine activity and participation of a patient rather than structural and functional impairments. But somewhere our training does not allow us, because हमें सिखाया गया एग्जाम में पास होने का है तो पढ़ाई करके पास हो. अगर मैं बोलूंगा क्या फर्क पड़ता है, कॉपी करके भी पास हुआ तो क्या? हम लोग को ये बोला गया, ये गलत है. So somewhere our training, our education does not permit us. But the moral of the story is pass होना था ना. Moral of the story over here is that the hemiplegic patient had to do whatever the functional tasks were there. If the environment is facilitating, it's okay. But our training always tells us, no, let's look at the structure, let's look at the function, let's look at the spasticity, let's look at the gait and take care of it. Why? Maybe when you look at his क्या बोलते हैं, structure and functional issues, maybe you will get him a better quality of life. So this just letting the environment do the job might get him a good activity and participation, but maybe he will not get a very good quality of life. So your intervention is adding to his quality of life. So please go ahead and do it. I'm contradicting my own self, I know that, but that is what my answer to the given question would be.
Thank you, sir, for your insight on the ICF. First of all, I would like to apologize myself for such technical errors which came last moment while we were hosting this meeting. But nevertheless, I think what you told us regarding the use of ICF for assessment, the use of ICF for management, this is what very, very helpful for undergraduate students. And then coding regarding the ICF is extremely helpful for postgraduate students. So I think all in all, this was a package for our physiotherapy students to what they should learn. I think take home message is that a clinician should deliberately understand whether they should intervene or they should not intervene, and then what level of intervention should be precise. I think that is what the take home message for me. People must be having a different take home messages for them. But yes, thank you so much, sir, for these presentations. And at the end, we cleared our concept regarding the ICF. I would like to thank our president, Dr. Navle sir, for providing us a platform and providing us all the required facilities. And a big initiative by Dr. Nisha Shinde Madam, our principal, who is promoting and helping us to conduct various webinars on different topics. I also thank my colleagues of Musculoskeletal Department, Dr. Richa and Dr. Priya, for helping me in entire process. And nevertheless, my postgraduate students were always there with me to conduct workshops and to conduct the webinars. Thank you so much, sir.
Thank you, sir.